All right. Might get started. I'd like to begin today's webinar by acknowledging the traditional owners of the land on which we're working today. For me, that's the Yagara and the Turrbal people. I would like to pay my respect to their elders, past, present, and emerging. And extend that to the lands on which you're all on as well today. I just wanted to let you guys know how we're going to work today. It's going to be a really brief webinar. We will try and get through the content as quickly as possible so that there's some opportunities for questions. We'll start with Andrea Vancia from the Brisbane South PHN, who's going to give us a little bit about the overarching why we want to support better access to healthcare for multicultural communities. I'll give you a little bit of a background about the program, and then Meryl, who's our nurse unit manager at Mater Refugee Health, is going to talk a little bit more about the type of work that the nurses are doing within the program. So I'll hand over to Andrea.
Thanks, Vicky. So we wanted to start off with what do we actually mean by multicultural? It's a question that does come up. So you might have heard terms like multicultural and culturally and linguistically diverse, which we often shorten to CALLED, and they're often used interchangeably, and they reflect the populations that aren't from the Anglo-Celtic majority of the Australian populations, First Nations people. So examples include migrants, people of refugee backgrounds, people seeking asylum, seasonal workers, international students, trans-Tasman visa holders, so people that come from New Zealand on a special arrangement they have with Australia, and the children from all the groups above. And as you can imagine, there's unique challenges across all the different migration pathways in terms of accessing healthcare. Next slide, Sam. So we know that culture and language impact health and well-being, and people from multicultural backgrounds, particularly non-English speaking backgrounds, often face additional barriers to accessing and navigating the Australian health system. These include language barriers, so for example, accessing interpreting service, there's health literacy, health system navigation challenges, cultural safety and appropriateness of the available health services, stigma and discrimination, and also socioeconomic and systemic factors. So examples would include things like not having a permanent visa and not being able to access certain health services in Australia. I also wanted to flag here the fact that all PHNs have access to the Multicultural Access Program now, and a large majority of the PHNs are also doing a needs assessment in the multicultural health space for their region.
I'm here, Sam.
Okay. Can everyone hear us? Everyone else can hear us?
You're clear for me, Andrea.
Okay, no problem. Okay. So basically just wanted to highlight that last talk point here, so everyone's aware that the PHNs are working to try and improve multicultural access for healthcare for our communities within our different regions. Next slide. We wanted to set a bit of context to the numbers within our region. So just sharing some data across the Brisbane South, Brisbane North, and Darling Downs and Westmoreland PHNs. So these are percentages of people born overseas. So we've got 31.1% in Brisbane South, 24.7% in Brisbane North, and 15.9% in Darling Downs and Westmoreland. And I just wanted to highlight here as well, this is from data from the 2021 census. I wanted to highlight the fact that we didn't go into LGA, and I know that in specific LGAs like Ipswich and Brisbane, there are higher numbers of people born overseas, but when you spread it across the whole PHN, it brings that percentage down. So this program is going to be specifically for Brisbane, Logan and Ipswich regions due to the high numbers in those regions of people born overseas. Next slide. And we've also got some demographics of people who speak language other than English at home. and who have low English proficiency. So those that chose in the census that they speak English, a language other than English at home, and they either speak English not well or not at all. And so we've got some figures there for each of the 3 PHNs. And to us, that's really showing the more vulnerable end of the spectrum where there's the language barriers on top of all the cultural and other barriers that people have to access healthcare. Over to you, Vicky.
Awesome, thanks, Andrea. So we just wanted to highlight a specific report that just was released last month, which is only one cohort of what this program will support, but it gives some really stark examples of why we're working in this space. So this was a report that was put out by the Australian Institute of Health and Welfare, and its title is Health of Refugees and Humanitarian Entrants in Australia. What it is, it's a data linking report that used ABS data with also the multi-agency data integration project data, and they've pulled off quite a lot of information in the first report from Medicare. They're looking into a second report at the moment that they've started, which is actually going to be based with the hospital and health service data. So there'll be more of these reports to come in the future. But what we wanted to do was just show you a really quick highlight of that information today so that you can have a bit of an understanding about some of the additional challenges. So of particular note, Sam, go to the next page. In the long-term health conditions, there are some areas in particular that are significantly higher for people from a refugee background. Kidney disease in particular was 130% higher compared to other permanent migrants and 80% higher than the Australian general population. Diabetes was also incredibly high. Life expectancy on a whole is 16 years less than the rest of the Australian population, which is really significant and stark difference. And it's part of the reason why this program has intentionally included people from a refugee background, but also people who are seeking asylum. The next slide, we're looking briefly at the leading causes of death in humanitarian entrants over the period of 2007 to 2020. And unfortunately, as you can see across both the male and female cohorts, these are, to a degree, preventable deaths. And so what we're looking at is how we can affect those outcomes for people, both in the primary care and the hospital health service space. We've also put in a slide there around the time of arrival in Australia, and actually the longer they're in Australia, it doesn't actually get better. It does, their death rates do also continue to go up instead of improve because of the better access to healthcare. And I've just done a very brief summary, which has some of the probably key information that came out of this, which is that there is a higher engagement in primary care services by this population group. So it's not that they aren't accessing care; they actually have 40% higher GP attendance, and they are having extra pathology done as well. Their life expectancy does remain lower, and that they have specifically longer-term health conditions that are higher rate than the rest of the Australian population, particularly for diabetes, kidney disease and stroke. Mental health, interestingly, is a flip of that where they're engaging in lower services and there's less antidepressant medications dispensed to this population group. So this is the data. There's obviously the reasons and the rationale why behind that, and that's also part of the ongoing work. So this is the first of a series of reports that are being released, and we hope to continue to see those, which will help inform the decisions we make when we're implementing programs going forward. Which leads me to actually why we're here today, which is to talk about the MARTA Multicultural Health Coordination Program. So if you just want to skip on, Sam, basically, I'll just give you a really brief overview. MHCP is a care coordination program. It seeks to increase the patient's connection between their primary healthcare provider and the tertiary services and or community services. Our clinical team consists of 3 full-time equivalent nurse, clinical nurses plus a social worker. They have quite a broad geographical region. We will support patients living in Brisbane, Logan and Ipswich areas who are from a multicultural background with complex health and or social needs. And services will be delivered from a variety of locations. I'll just go back to the background a little bit so you have the context about why this program has been funded. So the Multicultural Health Coordination Program is funded by the Queensland Health Connected Community Pathways grants. The grant aims to strengthen access to care in the community closer to home and through networked models of care and partnerships. The program concept came from the successful MCHOOS pilot that was delivered by the Mater Refugee Health Service in 2020 and 2021 when there was a pause in humanitarian arrivals. Children's Health Queensland, Metro North Hospital and Health Service, Metro South Hospital and Health Service, Mater and West Moreton Health, as well as the Strategic Policy and Reform Division at Queensland Health, Brisbane North PHN, Brisbane South PHN, and Darling Downs West Moreton PHN were all partners in this application. Each HHS utilised their local needs assessment to determine the need for the program before endorsing its application. These services have also formed a collaborative which is aiming at addressing the systemic barriers that are identified during the project and advocating for policy and service change to enable more equitable access to healthcare for this patient cohort more broadly. It's a new program and it's currently funded until the 30th of June next year. It does have potential though to become recurrent depending on the outcomes of the independent evaluation which is being conducted by QBT. I'm going to actually hand over to Meryl now, who will talk a little bit more about the actual core activities of the program and referral criteria and all of that stuff.
Thanks, Vicky. Can I just ask, when I hear Vicky speak, she sounds very broken and that nobody else's face seems to be reacting. Is everybody else having that sound issue or is that my microphone? Okay. Is my sound okay? Can you hear me clearly?
I can hear you clearly and it was a little bit crackly.
Okay, it's all right. Vicky and I are actually in adjacent rooms, so I apologise. I may also be crackly and my microphone is also not very good. So if you can't hear, please do just let me know and I'll see if I can do something about it. So Vicky's asked me, because I'm the team leader for the nursing team on this project, just to come and talk about the sorts of things that our nurses do every day. So what the core activities are. So all patients referred to the service have an initial intake assessment. So obviously the referrer, we would like the referrer to state what goals they would like the program to be able to address and what they would like us to be able to work with the patient to address. And that can be quite a short-term thing. We've had referrals for people from GPs just wanting patients to be supported to re-engage with outpatient appointments that are being cancelled because patients weren't able to understand text messages sent them about that, right through to people with some really complex health needs, which are being impacted by some really complex social needs, who we expect that we'll be engaging with for a much longer period. So at the moment, the longest period of time that we could engage with anybody would be with the license program, which would be until the end of June next year. So just to give you an idea of that sort of time frame, so we can see them. So as well as that sort of initial intake assessment, where obviously we will be having a chat with the person themselves about what they are hoping to get out of the program. There's a strong health literacy focus within the program as well. So as well as making sure that people link with the services that they need to address their healthcare and but also their social needs that are impacting on their health, we also want to make sure that people actually understand which services that they're linked with, and what and their health conditions, who is doing which bit in their healthcare, and what the need is to engage with those people. So we also working on a sort of family-centered approach as well. So while a referral patient, we see that person very much as being a part of a family unit. So looking to engage with family support as well. Like I said, focus on health literacy, so really making sure that people understand their health conditions, which in a cultural context obviously means that we are aware of, I guess, those differences where people may not actually understand their own health in terms of environmental level of healthcare. So often does need more unpacking of what people think is going on for them. And I guess the nice thing about this program is that this is actually have the time to sit with people, understand what their health beliefs are, and then hopefully meet them where they're at to be able to provide meaningful health education and health literacy support. We do have a social worker working within the program as well, which is wonderful and first for us. We do have just one social worker to 3 nurses. So she is very much independent, but again is able to provide advice to our nurses about linking community support and social services, and also available to work with people who are at that more complex end of the social spectrum and so referrals. So whilst the social worker is actually involved in sort of the initial review of all cases, she won't be providing direct patient care to everybody because that just simply wouldn't be possible. But it's certainly got to provide support to more complex people and also advance to those with program. And as Vicky said, also we have this sort of systems advocacy piece within the program, where basically nurses identify systems barriers that are preventing people from accessing healthcare. Can you still hear me okay? So where systems barriers are identified, we have this mechanism to be able to, through a stakeholder engagement group, to actually be able to raise these issues up for consideration within the sort of high-level stakeholder engagement group, which has representatives from HHS as well. So our referral criteria at the moment while we're establishing the program is very broad because this is really a sort of proof of concept. So we're open to taking referrals from a very broad criteria at the moment. So the catchment area is Brisbane North, South, Logan and Ipswich. Obviously it's intended for people from a multicultural background and those with complex health issues, or I guess it can be just one health issue, but if somebody has significant social factors which are impacting on their ability to engage with that one health issue, then we're happy to receive referrals for those as well. So I guess a sort of classic example would be that a person has diabetes, which is just one condition, but at the same time they need to be linked with lots of different services, and they have a limited understanding of diabetes and how to access the services that they need here. We would accept a referral for that person. So I guess that's a differential between us and some of the other pain coordination services, which are specific to a number of conditions or particular conditions as well. We can see people from across the lifespan as well. So whether they're children or adults, and there is no cost for the service. We don't have any eligibility requirements about whether people have Medicare or regarding support groups that they're on as well. There's some links in here, so if you're already thinking I know a person, there is a link to a referral form here. And for GPs in practices, we have feedback from GPs that they really like completing forms unless it's something that they can also generate from a practice software. So if they would like to write a letter instead, just to say good thing to a specialist, we're very happy to receiving those. Well, if it's really difficult, we're quite happy for people to just call us on the phone number and see at the bottom here. Again, as people, we can take self-referrals. So if somebody with limited English proficiency wants to refer themselves, the phone's up, they can phone us, tell us they need an interpreter, and call them back to complete that referral with them on the phone as well.
Thanks so much, Meryl. And the last part was because we know that this is a lot of our PHN partners and team leaders and as such from the Hospital and Health Service. If you're wanting to promote this program to your key areas. We've got a flyer, a website, and all of that information about how to access the program is all on that website, including the flyer, which has all the key information about the program. I have noticed a few questions have started to come in. Thank you for that. Please keep putting them into the chat and we can go through them. No problems, Connie, who's just left, I think. We'll make sure that we've got the recording of this session available and also the links, as I said, are all on our website.